just do a quick introduction. So my name's David. I'm the CEO here at Respire Medical. So tonight's webinar is about oral appliances and when to choose the certain oral appliances and some of the history in oral appliances and some of the nuances that maybe are just a little bit out of the norm from the usual discussion. So we have a very special guest tonight. So it's Dr. John Tucker is joining us to give the presentation tonight. Now, Dr. Tucker has been in private practice since 1982 in his own practice and is a board member of the Academy of Dental Sleep Medicine. And more importantly, I think he's even the president and founder of Tucker Educational Excellence and really one of the best speakers in dental sleep medicine in the world. So you'll not meet many better speakers than John Tucker. And I think anybody who knows him would echo that as well. So it's a privilege and an honor to have him here. So JT, I will pass it over to you. People are still starting to filter in, but I'll let you kind of kick things off. So thanks everyone for joining tonight. I hope you enjoyed the webinar.
David, thank you for the kind introduction, but kudos goes back to you. I've known you since your inception of Respire and been a client of yours for years. And one of the things I admire most about you, David, is the fact that you're actually a CDT. So you understand what needs to happen from a laboratory standpoint, and you can communicate back to us as the treating dentists of what we need to do to provide an outstanding treatment outcome. You have an outstanding, phenomenal product. We're going to talk about that tonight. So thank you for being one of my mentors and assisting me in this 18-year-long journey of being involved with sleep in my dental practice.
Thank you. The privilege is mine, but thank you.
Oh, you're welcome, my friend. Plus, we do have fun when we're together. It's been over a year since I've seen you personally, David. So, hopefully when things break up and hopefully later in 2021, we'll be able to do some programs live. So
yeah, I think there's a bar with our name on somewhere. So we need to do that together.
David, that's always the case when we're together. And then we get our dear friend Elias Kalanzis involved and it's lights out. So you have to excuse me, my allergies have been going crazy. So, and I've been speaking a lot the last 2 days, so my voice is kind of shot. Conflict of interest, I have none. I don't own anything. I don't own any products. I don't have anything to push or sell you. The only thing I have to share with you is my knowledge, and that's why I'm here this evening, is to impart to you my experiences and what the literature says about oral appliance therapy. So tonight we're going to talk about different oral appliances. And, there have been lots of programs on oral appliance therapy, and I hope to give you some new information and to impart some things that you may or may not know about. So hopefully all of you know this is old news, but to some it's new news. That the American Academy of Sleep Medicine said back in February of 2006 that oral appliances are indicated and used for mild to moderate OSA for those who prefer them to CPAP, do not respond to, not appropriate candidates for, or those who fail attempts with CPAP. The reason I bring this up is, David, it's April 15th, tax day, 2021. And I still have people in the medical community say to me in 2021 that oral appliances don't work and they're not indicated. It's like, well, that baffles me because in 2006, the American Academy of Sleep Medicine endorsed us to be part of the treatment protocol for those patients that have a sleep-related breathing disorder, such as obstructive sleep apnea, and are not candidates or fail CPAP therapy. That was updated in 2015 in the Journal of Clinical Sleep Medicine by the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine. And you can see what they say here. Bullet point 1, which I think was very well needed, was that sleep physicians should prescribe an oral appliance rather than no therapy for those patients that have primary snoring without obstructive sleep apnea. Obviously, we want to use a custom titratable appliance over a non-custom appliance. That's why I love Respire, and we'll talk about their appliances. And sleep physicians should consider a prescription of an appliance rather than no treatment for adult patients with obstructive sleep apnea who are intolerant of CPAP therapy or prefer alternative therapy. So here are the new guidelines. And so for those people that say appliances are not indicated, I suggest you review this with those individuals that make those comments to you. So the code, excuse me, is the E0486, which is an oral appliance used to reduce upper airway collapsibility. That's adjustable or non-adjustable, custom fabricated, and it includes the fitting and adjustment for the first 90 days of therapy. So I get a kick out of ads that I see, and David, we've talked about this before. The correct terminology is FDA cleared, not approved. So when you see the words FDA approved, typically that's when you'll see the OTC, over-the-counter appliances. They'll say that they're FDA approved. That's not the correct terminology. The correct terminology is FDA cleared. So let's look at a little bit of science for a while. This is by Eckert et al. I want to look at the non-anatomical pathophysiological phenotypes. So 81% had an anatomical PCRET. We'll talk about that in a second. 36% had inadequate upper airway muscle responsiveness. 37% had a low respiratory arousal threshold, and 36% had an oversensitive ventilator control, which means high loop gain. And we don't have time tonight, and tonight's not about loop gain, but loop gain is absolutely one of my favorite topics in sleep. So let's take a look at this work by Edwards et al. That looked at non-responders and responders. So you'll see in blue, the less collapsible upper airway were the oral appliance responders. Those that had oversensitive ventilatory control or high loop gain had a more collapsible upper airway, and those were the non-responders. Now, it's very difficult for us to, this is great science, it's great esoteric information. Unfortunately, most of your sleep labs are not going to look at loop gain, but it's just, I think it's a good idea to give us an idea of what's happening to the airway and understanding the non-anatomical traits and the response of our appliances. So treatment options. So if you're looking at loop gain, you can use O2, CO2, Diamox, which is a diuretic. If you have low respiratory arousal threshold, you can use Lunesta, which increases respiratory arousal threshold. And that's an interesting concept of using Lunesta. If you look at the upper airway dilator muscles, we're going to talk about this a little bit. You can use Strattera, which is used for ADHD. And a norepinephrine reuptake inhibitor, as well as Ditropan XL, which is a bladder relaxant. And in the combination of both of these medications increases genioglosal response during sleep. We're going to talk about the tongue because since I've been on this journey, my big focus has been on the genioglossus. And I'm going to share with you something really new and unique that I just experienced yesterday, and it all has to do with the genioglossus. Now, what you need to understand is everything you see on this screen here, as far as treatment options go, these are completely outside the scope of our treatment. Once again, completely outside the scope of our treatment. This was work done, as I said before, by Eckert et al. But I think you need to understand the science of what's starting to happen with controlling the upper airway and what science is doing to try and control the upper airway. So this is focusing more on a medication treatment protocol. Once again, this is for your edification and understanding of current science and literature, but is completely outside the scope of our treatment. So when you added the two drugs together, you got a very positive response of the genioglossus. Now, you had to have both medications in combination as compared to using them individually. And this shows the genioglossus muscle activity with EMGs with the two medications compared to a placebo, and you get increased genioglossal tone and response. So what are the clinical predictors of oral appliance treatment outcome? I think we're all looking for that. And dentists, we all want to know what the, just tell me where to set the appliance, right, David? I'm sure that's probably the biggest question you get. Where do I set the appliance? And I wish we all had a finite answer for that, but that's yet to come. So we know that those that are younger, with a lower BMI, a female gender, a smaller neck circumference, a smaller overjet, and a Mallampati score of 1 and 2 are better clinical predictors of oral appliance treatment outcome for oral appliance therapy patients. So when you look at gender differences in an appliance efficacy, men are in blue, women are in red, and you can see the overall success rate for women is higher than men. So those that responded with an AHI of less than 5, we see the females are greater than the males. An AHI of less than 10, once again, females respond more than males. And once again, an AHI of less than 15, it's the females are better responders than males. So we've seen this before in the literature that females seem to be a better responder towards oral appliance therapy. So what is the goal of oral appliance therapy? What are we trying to do with our appliance? Well, we're trying to relieve the upper airway obstruction during sleep. How? By modifying the position of the mandible, automatic CPR, if you will, with the tongue and the pharyngeal structures. So what do we want? We want to have a bigger, more stable airway during sleep. That's our goal with our appliance, is to maintain the airway during sleep for our patients. So let's start to look at some different appliances. Well, I think, David, this is now over 187, probably approaching 190 FDA cleared designs. And I think that's really fascinating. And my thoughts are, all dentists are either MacGyvers or MacGyverettes. We all seem to come up with a different design or a different technique on something that we can feel that perhaps will provide a better treatment outcome or is just an easier product to use. And I applaud our profession for doing that. I think we all like to think outside the box. So we have 3 different designs: the MRA, that are appliances that advance the mandible in a protrusive position, a tongue retaining device, and then of course combination therapy using an oral appliance that would lower the air pressure or PAP therapy. So the question is, which one? What a great question. I wish I could answer that for you with truth and sincerity. The answer is there have not been really good studies that have looked at one appliance design over another. I have my personal opinions that I will share with you this evening. I try and base my opinions on science and what seems to make logical sense to me. And that's what I will share with you this evening. So if you look at this work by Chung et al., the oral appliance needs to be engineered to allow as much tongue space as possible so that it can get out of the airway. If the appliance is too bulky, it will encroach on the tongue. The tongue acts as a muscular hydrostat, and that means it will move into any space available, thereby retruding into the oral pharynx and exacerbating the situation. So I don't have the time this evening to talk about the tongue being a muscular hydrostat, but I would ask you to please Google that if you want more information about it. So, as I said before and alluded to me personally, and what made sense to me was the tongue was the huge offender of the airway. I've said for years, it's the beast of the airway, it's the cork of the airway. So I've been enamored with things that allow the tongue to get up and out of the airway. And we'll talk about that with oral appliance design. And since 2010, when the STAR trial came out that talked about hypoglossal nerve stimulation, cranial nerve number 12, they looked at what would happen if you would stimulate the hypoglossal nerve, that when that is stimulated, that 12th cranial nerve, it actually compacts and protrudes the tongue. Well, then they started to look at DISE, drug-induced sleep endoscopy, to see where the collapse was of the airway. I don't have time to go into DISE this evening. Very interesting. Followed it, like I said, since 2010 when the first STAR trial came out. That led to the development of a product called Inspire. Inspire is hypoglossal nerve stimulation. It's a device that's implanted into the subclavian area. One lead goes to the intercostals, another lead goes to the 12th cranial nerve, the hypoglossal nerve. It's controlled by a remote that when you go to sleep, you turn it on. The pressure indicator senses a lack of breathing. That activates the generator to stimulate the hypoglossal nerve, and the tongue protrudes and gets out of the airway. Very effective, certain protocol that has to be followed. Yesterday, I was so honored to be the first dentist that was invited to the Inspire cadaver laboratory, and I was actually able to surgically place an Inspire unit on a cadaver with my surgeon that will be placing them in Erie, and it's been the pinnacle of my career. Just absolutely phenomenal. So
Yeah, I don't think that point can be understated, Tucker. What you did yesterday when you'd send me that picture over, I was blown away that not only a dentist could do it, but you were the first to do it. So I think that's kudos to you, and that'll go down in the history books for sure.
thank you so much, David. Yeah, huge honor for me. Um, Humbled beyond belief. Can't thank the group at Inspire enough. Geraldine White, the rep from Pittsburgh that got me into that. And I think that we're going to see some cool things that come of that. And the medical dental collaboration that's going to come out of that, I think is going to be great for all of us. Is it going to circumvent oral appliance therapy? Absolutely not. So you don't need to worry about that. It's just another alternative treatment for patients that have a sleep-related breathing disorder, can't tolerate CPAP, and can't tolerate an appliance. So stay tuned for more of that. Great stuff to come, and thanks for your kind words, David. It was beyond belief. So the oral appliance acts to advance the suprahyoid and genioglossus muscles, enlarge the airway, and stabilize it. And that's actually what we see happens with Inspire. It improves the velopharyngeal airway space via the palatal-glossal and palatal-pharyngeal muscles. They create tension on the soft palate, decrease vibration, collapse in the forward position of the mandible, pulls the tongue off the back of the throat. So that's how this works. That's how our appliances work. And I think it's important that you understand how the appliances work, because what are you going to say if one of your sleep physicians says to you, hey, how do these appliances work? I think you need to be educated and understand that and be able to give them a 2-minute dissertation. You don't need to give them an anatomy lesson, but explain to them how the appliances work. We want to increase the upper airway dimension, stabilize the position of the mandible and the hyoid bone. We want to bring the hyoid bone more superiorly, and the increased muscle activity in the upper air, increase muscle activity in the upper airway during sleep. So how do they work? I think it's a great question. Well, there are only 2 ways you can move the mandible that I know of. You either pull it or you push it. So we're going to take a look at different mechanisms of action and different mechanism of actions of appliances. So once again, push the mandible horizontally, protrusive, or pull it. And then we have interlocking monoblock devices. So the push-pull from the anterior are the Dream Tap and the Lamberg, both nice appliances. My personal opinion is appliances that have hardware in the midline. If you're trying to get the genioglossus up and out of the airway, it seems to me from a physiological standpoint and an anatomical standpoint and logic, that why would I want something in the midline with my appliance that would block and inhibit the genioglossus from getting up and out of the airway? Once again, this is one man's opinion, totally my opinion. Not a lot of good science on that, but we see the way that Inspire works by stimulating the hypoglossal nerve, cranial nerve number 12, to compact and protrude and get the tongue up and out of the airway. Then we have my personal favorite, and purely my opinion, and I'll give you reasons why. It's the Respire Pink AT. It's a bilateral push. It's a herps with a new arm. I'm going to talk about that, excuse me, and why this is my personal favorite. You have bilateral pull, which be an EMA, a Silent Night, or the Panthera. The interlocking monoblock devices, dorsal device, a Clearway, the Moses, and the Micro O2. So pretty much those are the designs currently available to us for providing oral appliance therapy to our CPAP intolerant patients. You can look at provisional appliances. Silent light can be looked at as a provisional appliance. You can look at a tongue retaining device, the MyTap, and various boil and bites. They're nice provisional appliances, but I don't see them as being great long-term solutions for treating the sleep-related breathing disorder patient with obstructive sleep apnea. So we're going to talk a little bit about titration. If you go back in time and look at all the different devices that are available to us, you have to understand that the titration of most of the devices and the protrusive mechanism all came from the ortho world. So some unique designs were the EMA that had these elastic straps that came in different lengths and strengths. The shorter the strap, the greater the protrusion. And every device would have some type of different titration mechanism. So you really had to pay attention to what that mechanism was and what the lab was using, because they were not specific, they were not standardized across the board, meaning each device had a different titration mechanism, and you had to know and follow what that was. So what we're trying to do with our titration is find that ideal target of where the maximum opening is for the airway to alleviate the patient's sleep-related breathing disorder and decrease the AHI. Once again, every device had some type of different titration mechanism. So the device you see on the left, you had to titrate in the direction of the arrow, and it depended on that palatal jack screw, how many turns equaled 1 millimeter. Sometimes it was 8, sometimes it was 4, sometimes it was 10. And you also had to realize that you titrated in the opposite directions based on the appliance. So the right side titrated in one direction versus the left side titrating in a different direction. As I alluded to before, the DMA, different lengths and strengths. Shorter the strap, the more protrusion. Then your traditional Herbst arm had these little holes, and each quarter turn was 1/16 of a millimeter. So it was kind of confusing for me and for patients of how to titrate. So prior to COVID, I never let patients titrate their appliances because they would always mess it up. Even if I would let them try the titration on a demo model, they'd come back and they would advance one side and retrude the opposite side. And then we had problems with the Herbst mechanism with that nut, that it would loosen and one side would be more protrusive and the other side would be more retrusive. So it was kind of confusing. COVID hit. Patients didn't want to come in for follow-up visits. We did a lot with telemedicine. I've done programs talking about how we use Doxy.me, which is a telemedicine program that's HIPAA compliant, and it works well. But we still had problems with titration, and even if I had patients use FaceTime, they still had a difficult time in trying to titrate their appliance. So let's talk a little bit before we get into the AT a little bit more in depth about appliance selection. Remember, this is all opinion, opinion, opinion. So I like appliances that don't splint the mandible to the maxilla. I personally believe that the mandible should not be splinted to the maxilla to allow more freedom of movement. I think that lends itself to less joint issues. And then the most important thing is I want my appliance to have low volume, no hardware in the midline, so that I can allow the genioglossus to get up and out of the airway and clear it. David, that was an awesome video that you guys put together regarding the pink AT. So I'd like to go through some of the specifics about the pink AT and why it is my personal favorite for providing my patients with oral appliance therapy. So I think, David, one of the first things is with COVID is with the new titration key that we turn everything in the same direction, there is less chance of error for the patient to inadvertently titrate their appliance. And with the old Herbst arm, 1/4 turn was a 16th of a millimeter, so that meant 16 turns. So instead of 16 turns, I only have to worry about 4. And so I can actually watch the patient titrate their appliance with the titration key. And I think the most important thing is that integrated scale that you now have on the AT arm, that you can actually visually see the titration to make sure that the bilateral titration is symmetrical, meaning that you haven't titrated one side more than the other. And the other great advantage is instead of 5 or 5.5 millimeters of advancement, I now have 7. So what does that mean to me? Well, I can be a little bit more conservative where I set my bite. So if I don't want to go as far protrusive or horizontal, I know that I have the ability to provide 7 millimeters of advancement with the new AT arm.
Tucker, if I can just jump in on that one
Jump in,
point.
please.
I think, I think what we see a lot in the lab side of things is that people do want to be conservative with their bites, but if you're using a device that only has, 4 or 5 millimeters of advancement, then you are kind of restricted then. What that really leads to is more resets, which means taking the device away from the patient, having the bite reset to a more protruded position so you can advance further. So one of the goals with the 7 millimeter advancement is that you can be more conservative without running out of runway, as it were, to advance the patient. So hopefully that reduces taking the device away from the patient, and maybe even less patient visit, because it is very, very easy to titrate. As you said, it's not complex in any way. So yeah, hopefully that helps.
David, that to me personally is one of the biggest assets of the AT design, is being able to have that advancement ability for my patients. And like you said, to go a little bit more conservative if I want to on my initial horizontal advancement.
There's one question just came in actually,
Yeah.
JT, about how you take your bites. I know, we're both fans of the airway metric system. So would you mind just sharing a little bit about the airway metric system, or how you prefer to take your bites? Just to maybe, I know that's quite a, it's not something you can answer in just a quick one, but I don't know if there was a quick thought you had on that.
Well, my friend, we're going to take a shot at it, the two of us. So I first started out with the George gauge. That didn't make a lot of sense to me. I met Dr. Bob Horchover, who developed the airway metric system, and that has a vertical and horizontal component. And that made a lot of sense to me because I am a vertical believer. And I always love people that tell me there is not a vertical component when it comes to oral appliance therapy. And I find it hard to understand that comment because, David, you and I both know you more than anyone as the lab manufacturer that posteriorly you need 2 millimeters of vertical posteriorly for the maxillary arch and the mandibular arch, correct?
Yeah, sometimes even more if that curve of Spee is really steep.
So that was leading me next to two of our favorite subjects that I think are highly overlooked, are curve of Spee and curve of Wilson. And a lot of times in our programs when we were together, we'd get that deer in headlight look about what is curve of Spee and what is curve of Wilson. So for me, the airway metrics, with me being able to control my vertical with, it has keys that are 4 millimeters, 6 millimeters, 8 millimeters, 10 millimeters, and 12 millimeters of vertical. And then horizontal, anywhere from edge to edge to 7. I can pretty much control where I want to start my bite. So the first key I would use is the 4 millimeter edge to edge, because that would be the least amount of horizontal and the least amount of vertical. So when I place that key, the first thing I look at, David, is curve of Spee and curve of Wilson. Mm-hmm. And I think that's the first thing that people need to pay attention to, because you and I have both discussed the fact that they don't have enough vertical for you to fabricate the appliance. And then when you question the doctors about that, they tell you just open the bite, right?
Yeah. In opening the bite in the lab is, it can be done, but it is a guesswork because we're not moving the jaw and the articulator in the same way that the jaw would move.
Correct. So, my new way of instructing people in use of the airway metrics is, place your 4 millimeter vertical key in the edge to edge notch. And first thing you look at is posteriorly, do you have enough vertical for the appliance? So you have to pay attention to curve of Spee and curve of Wilson. And if you don't, then the next thing you need to go do is go to the 6 millimeter vertical key. So you can actually check out the way that I personally do the airway metrics bite on my YouTube channel. It's Tucker Educational Excellence. And there's a whole segment of how we use the airway metric system to take our bite.
One last thing, if I can, just on the vertical, I think the good thing with the Aerometrics is it has quite a range of verticals. It's not just an option of two vertical positions. So if you have a TMD patient who you can't advance that much because of concerns with the joint or some kind of disc displacement, then you have more options with verticals and not just stuck to two, I think 3 and 5 that you may get with some. So yeah, I think it's a great tool. I'll encourage anybody to learn about it. It's from a company called Kettenbach who own it now. So yeah. Anyway, sorry, I didn't mean to interrupt about the bite situation. I know we could talk about that all night. That could be a webinar
Oh,
within
I mean,
itself.
yeah, we could do a whole webinar and spend a couple hours on that, but
Yeah.
the words of wisdom I have for everyone, David, and I've said this before, you don't want to add so much vertical that you encroach on lip competence, meaning that they can't get their lip sealed. Because if they can't get their lip sealed, then we've now created a mouth breather. And we know the correlation between mouth breathing and sleep-related breathing disorders versus nasal breathers. So don't go too crazy with your vertical. I think this is a really great advancement that you guys did with the new AT arm. That the friction that holds the screw in place, because anybody that's done a Herbst have seen the Herbst nuts move. So David, you want to talk a little about this resistance layer that you guys created?
Yeah. So we looked at the original device that we were providing and even some of the other devices on the market, and we looked at what were some of the long-term effects and some of the long-term challenges. And one of them is that the screw wasn't holding position. So obviously that can be really frustrating if you advance a patient to the sweet spot of opening their airway, and then all of a sudden they're not doing so well and they lose confidence in the device. So maintaining that position was really, really important. So we added a layer, a coating inside of the screw, which creates some resistance as you turn the key. Now it doesn't lock it, or it doesn't prevent you from turning it, but it just adds that resistance. So it doesn't wear away over time, so it can fall back to another position. So a small and something you can't even see because it's inside of the barrel, but really an important point in the longevity of the device, I feel.
So what I've thought about, David, is for anybody that does things with mechanics and engines and screws and whatever, there's a product called Loctite. And it's almost like and you don't have to tell me this, but I mean, as I titrate my appliances, I feel that resistance. It's kind of almost like there's Loctite on that. So I get it. Great, great advancement for the arm. We talked a lot about the key. Very easy for the doctor to titrate the appliance. And the other thing I think is, congratulations to you and your team, David, that it's a large enough key that now, since COVID has transpired and we're doing more telemedicine visits, and we're letting the patients actually titrate their own appliances. A lot of the patients that are seniors that may have some manual dexterity problems, your appliance is approved by Medicare. This key is great because it's got that big wing on it that provides easy access and grip for our patients. And then once again, I mean, it's really easy for the key that inserts in the back of the hinge. It seats, my analogy is, David, just like an 050 implant hex driver. It seats perfectly, and that you're engaged into that hex. And once again, 4 turns would equal 1 millimeter of advancement per side. And once again, it's important that what you do to one side, you do to the other. So if you advance one side, the left side 1 millimeter, obviously you need to advance the right side 1 millimeter.
And one point about that titration is that, both sides turn in the same direction. So you don't have to tell the patient to turn, the left-hand side counterclockwise and the right-hand side clockwise. So both are just counterclockwise. So it makes the instruction a little bit easier too.
Yeah, that opposite, David, there was not one patient that ever completely understood or grasped that design. And that's why early on, I tried to let patients titrate their own appliances. And I never had a patient that didn't unsuccessfully titrate their appliance. So that's why I said no more keys to the kingdom. Now I give the keys to the kingdom to the patient with the AT arm, because all you have to tell them is turn it in the same direction. And once again, easy to do via telemedicine. So less corrosion, right, David?
Yeah. So the corrosion, a lot of that comes from the inside of the coil and how the coil is cut. Not to get too technical, but you can cut a coil with a laser cut, or you can do it on a lathe. And we did a lot of research into which one is the stronger over time and which one is the finer of the two. So inside of the coil doesn't degenerate and start to disintegrate, as it were, and start to lock up. But yeah, important point of how clean cut that coil edge is, so it's a nice smooth turn and it doesn't get locked and doesn't deteriorate.
It's fantastic. So, I love the slim design, David. And the other thing is this, my protocol is that when we initially seat our appliances, we actually remove both arms and we seat the maxillary component first, the mandibular component second, verify their fit, make sure that there's no rock or roll, just like you're doing with any removable prosthesis. Then we reassemble the appliance. In the old days, David, there was a right and the left, correct?
Mm.
And my biggest fear in teaching that technique was to make sure that you got the proper arm on the proper side. So since these are unidirect or bilaterally direction, right? There is no right or left. That's a great thing that we don't have to worry about. I think this is probably the two things I see that are the biggest benefit are the adjustment key and the measuring scales, David. This to me is a no-brainer, because once again, the patients can actually see how much they've advanced the appliance. And if you're doing telemedicine, it's very easy for you to check the advancement by simply having the patient show you the appliance and the arms to see how much they have advanced each side. So to me, this is a great addition and great modification and advancement in this arm.
Yeah, thanks. I think one small note, this might be very obvious, but those numbers don't show up until you advance the device. So if you just slide it back and forward with your hand, you're not going to see the numbers. When you advance it and you turn it, then you see the numbers on the arm itself. Just maybe obvious, but certainly we've had some questions about that.
David, I'm going to ask you to repeat that again, because I think that's a really critical point that a lot of people are going to miss, and they're going to make phone calls to you and say, hey, my appliance doesn't move. I tried to advance it and I don't see any numbers. So can you repeat that again once more, please?
Yeah, so as you hold the device in your hand, it has a lot of freedom of movement. So you can move it side to side, and it has some play to move forward and back, quite a lot really, so the patient's not locked into a position. But as you slide it left and right, back and forth, you won't see the numbers on the arm itself, because that's the two barrels sliding over each other. It's not until you put the key in and actually advance the device and really bring that jaw forward are the numbers going to show up. So they are there. I can promise you they're there, but you won't see them until it's advanced.
Awesome, great. And One of the other big features of why I love this design is exactly what you just said, David, is the ability for the mandible to go into lateral and excursive movements so that we don't lock the mandible in position. Like I said, that was one of my big things. I don't think the mandible needs to be splinted to the maxilla. So for somebody that has severe parafunction, I think this is a great device because it allows that mandible to go wherever it wants to go, except in a retrusive position. So David, I'm going to let you take this one for a second. I love this chart that you've put together on recommendations for patient conditions. So I'm going to let you take a couple minutes and talk about Respire, blue, pink, the micro, and the EF.
Yeah, so the blue is our dorsal fin design, so it's not connected between the upper and the lower. So that's helpful if you have a patient who's maybe slightly claustrophobic and you don't want to put something really big in there. You can put the upper component, let them get comfortable, and then put the lower component in. And because it's not connected, I think the patients like that idea. Now, the EF version stands for Endurance Framework, and essentially this is a chrome framework. Two benefits. One is that, of course, you get the strength because it is a chrome material, but the other is that it's extremely thin, so you're really maximizing the tongue space. So there's no acrylic in the anterior, and there's very little material on the lingual all the way around. And because it is quite a rigid material, it only has to go over the height of contour. You don't have to extend it beyond the gingival margin, or even down to the gingival margin in some cases. So very short on the lingual. Obviously, no acrylic in the anterior. So if you have a patient with a smaller mouth or even just a very large tongue, and you're wondering what device, there's really no material that we can get that's as thin as this, because ultimately, if you're going to make an acrylic this thin, it would fracture, it would be way too brittle. So the chrome material really helps with that. The micro version is kind of as it sounds, really. It's a shorter arm. It's around 20% shorter. Now, because it is shorter, you do get a little bit less advancement on this. So we added an extra fixing element to the upper component. So if you do max this one out, you can simply unscrew it, move it forward to the next titration fixing element, and then move it further forward from that point. So the chart itself here, I think, is helpful for the team, really. It's the team in your office as they're talking to patients and they're asking, okay, like, what device is suitable for me? Some doctors, like to stick with the pink AT for the majority of their cases, and that's great. But I think also sometimes patients want a choice, and you want to put them in the device that's more suitable for them. So whether the patient has a small mouth or large tongue, a narrow arch, high vaulted palate, sensitive teeth, or they're going to be having some dental work done coming up in the future, more of a TMD patient, TMJ issues, bruxism, gagging patients. This chart is designed so when the staff are communicating with the patients, that they can just help guide them to the right device. So there's a lot of kind of information to read through here, but we certainly have this that we can send out if anybody is interested in doing that. And of course, with the DentiTrack compliance monitor, we can put that onto any of our the Herps designs that you see there. So any of the Respire Pink designs, whether it's the AT, the EF, or the micro. So that's the design we can put on there. And then of course all of the pink versions, everything on the right hand side is approved for Medicare as well, for those who are thinking or in the process of dealing with Medicare.
Great, thank you for that great synopsis. I love this chart. I think this says it all. It's very easy to follow. And the big thing for those of us that do work with our Medicare patients, the AT, the pink AT design is Medicare approved. So David, we finished a few minutes early. So I will let you field any questions the group may have. Here's my contact information. Should you have any questions, please feel free to email me at my email address at jtucker@tuckereducationalexcellence.com. Our website is tuckereducationalexcellence.com. We do provide online, in-person personalized coaching training for sleep-related breathing disorders and oral appliance therapy. And based on what happened to me yesterday, David, stay tuned for some killer new education.
That's great. That's great. Thanks so much, Doug. I think there's two questions that have came in, and whether devices, how would you feel about making them over the Vivera retainers from Invisalign? So we have done this with the final retainers. What we've often done is made the hard soft version. So if you take the impression with the retainers in the mouth, and then we would make the hard soft version, and we could make it the all acrylic version as well. But I feel as though the soft just puts a little bit less pressure onto the teeth and still covers every surface of every tooth. Of course, you're not going to get any tooth movement, but just a little bit softer. And then the other question that came in was regarding the acrylic shades. Are they available? So technically, yes, they are. We could send you some acrylic. Just shipping acrylic becomes a little bit tricky because it is quite a hazardous material. So it becomes quite an expensive process to do that. So, but really to reline them, any orthodontic acrylic can be used. And really with it being quite a clear acrylic that you can't see too much of the clear acrylic. So it's possible. Anybody who really needs us to send acrylic to them, just let us know and we can look into that with our shipping companies and see how it is. So I think that was all the questions that came in. So thanks again, Tucker, for jumping on here. It's been a pleasure. I know you've had such a crazy week with Inspire, but so thank you again. Thanks to everyone watching. We'll be following up with everyone tomorrow. And please feel free to reach out with any further questions. Thank you.
Thank you, David. Have a great night, everyone. It's been great being with you. Appreciate it.
Thanks. Good night, everyone.
Good night.